Hello, Shishir.
Hello, good morning, sir. Shall I start, sir?
Yes, start. Okay.
Okay. Good morning, everyone. Today's seminar is on the topic cataract surgery in silicone oil field eyes. So first, coming to properties of silicone oil. Uh, Coming to specific gravity, so this explains why an intraocular tamponade such as silicone oil sinks or floats in aqueous humor. So any substance with an specific gravity of 1 are neutrally buoyant in water. Those with specific gravity more than water will sink, and those lesser than water will float. So specific gravity of aqueous or vitreous humor are greater than water. Since the specific gravity of silicone oil, that is 0.97, are lesser than water, the oil always floats in the vitreous cavity. So coming to interfacial tension, when two immiscible agents are used together, such as silicone oil and aqueous humor or water, the interaction that occurs at the surface of these substance involved is named as interfacial tension. So it is responsible for the shape of liquid bubbles. Therefore, a substance having higher interfacial tension will have greater tendency to stay as one large bubble without dispersing into smaller bubbles. So coming to viscosity, the viscosity is physical property of a fluid which measures its resistance to gradual deformation by shear stress. So the tendency of a substance to emulsify and disperse into droplets over time, it is also dependent on viscosity. So if we use higher viscosity silicone oil, so tendency to emulsify is low. So and if we use the lower viscosity, so viscosity is generally will measure in centistokes. So oils are available from 1000 to 5000 centistokes, which are commonly used. So the lower the viscosity, higher will be the tendency to emulsify. So silicone oil generally have high viscosity, and once dispersed, the small droplets tend to recoalesce back as a large bubble. So coming to some of the common indications of silicone oil use. So it is used in retinal detachments, especially complicated with a proliferative vitreoretinopathy. Since here we require longer tamponade, so generally gas and air is not preferred. So silicone oil is the indication in these cases, and even in diabetic tractional retinal detachment. So here, apart from providing tamponade and keeping retina attached, silicone oil also prevents the post-operative hemorrhages, which are retinal hemorrhages, which are more common in diabetics. And it also prevents anterior chamber neovascularization, rubeosis iridis, and potential neovascular glaucoma in these cases. So coming and in chronic and persistent macular hole, generally the fresh macular hole, which is smaller, are generally managed with 20% SF6 gas. But in cases of chronic and persistent macular hole, silicone oil can be preferred. And in cases of colobomatous retinal detachment, and in patients who cannot maintain position, patients who has to fly. So if patient has to travel by air route, then gases are not preferred, as it may suddenly expand and increase the IOP and lead to further complications. So in such patients, oils are preferred, and even in very old patients who cannot maintain position for a long time, oils are preferred. And even silicone oil can be used in cases of endophthalmitis also. Here, the oil may act as an antimicrobial, and it helps in better management of endophthalmitis cases. So these are some of the common indications. So coming to cataract formation post retinal surgery, uh, it is almost nearly 90 to 95% of the patients who underwent cataract surgery will develop, who underwent retinal surgery will develop cataract in their lifetime. So the factors responsible are intraocular gas or silicone oil. So the tamponade itself can cause retinal surgery. Tamponade itself can cause cataract. Because the silicone oil or intraocular gas may to some extent hamper with lens metabolism, leading to the formation of cataract. And direct instrument touch during the retinal surgery, because these surgeries generally take longer time. So inadvertent touch, instrument touch to the posterior capsule or to the lens can induce cataract. So here the cataract formation will be very rapid. So if you are seeing a rapid cataract formation in a patient who underwent retinal surgery, we have to always assume that there might have direct instrument touch might have occurred. Then progression of senile cataract. So generally progression of cataract is faster in patients who underwent retinal surgery, and obviously diabetics undergoing VR surgery. So generally diabetics have faster rate of cataract formation, and on top of that, if they have underwent VR surgery, then most likely they'll develop cataract. So before coming to surgical techniques, I would like to tell about the biometry in silicone oil filled eyes. So here generally partial coherence interferometry is preferred. That is optical biometers are preferred to calculate the IOL power required to implant. If if it is not available, or you cannot use that optical biometers in very total cataract or very dense cataracts, then we have to go for ultrasound measurement of biometry. So the to measure this thing, axial length and IOL power by ultrasound, we need to keep in mind that sound waves travel slower in silicone oil as compared to in the normal vitreous. So if the sound waves travel slower, than to reach to the retina and come back to that ultrasound probe, it will take more time. So it will falsely interpret the more axial length. Axial length will be falsely higher when we use ultrasound methods. So to counteract that, the general rule is to multiply the apparent axial length which we get by doing ultrasound by 0.71 to get the actual axial length. So once the actual axial length is calculated, you can add plus 2 to 3 diopters more, because the silicone oil which is there in the vitreous, it will always act as a minus lens. So to counteract that hyperopic shift, you will add 2 or 3 diopters more. And then we have to explain patient that once silicone oil is removed, there will be likely that he'll be having a myopic shift. So these are some of the measures which you have to take to do the biometry. So if you use optical biometer, its accuracy is more, because here we are using the light rays to measure the axial length. So the difference won't be so much. Then coming to usage of choice of IOL, generally acrylic or PMMA IOLs are preferred. Silicone IOLs are not preferred because the silicone oil may get added to the silicone IOLs and then form the opacity in the IOL. So acrylic or PMMA IOLs are preferred. If plan is to implant the IOL in the sulcus, then three-piece IOLs are preferred. So both hydrophilic or hydrophobic IOLs can be used. So then coming to surgical techniques, clear corneal wounds are preferred. Phacoemulsification is the standard of care, and it is better than SICS even in silicone oil filled eyes, because scleral tunnel is avoided because there is more chances of episcleral scarring and bleeding, which are common in these patients. And sometimes the patient might have undergone even scleral buckling also, so it becomes difficult to create the scleral tunnel. And the main goal is always to keep the positive pressure in anterior chamber to avoid silicone oil migration into AC through weak zonules. So chances of silicone oil migration is high because of its property. It will always float in the vitreous, and it will always be giving positive pressure to the posterior capsule. So AC collapse is very common, and migration of silicone oil, either it can occur due to posterior capsular rupture, which might have occurred even during retinal surgery itself, and or else at least there will be high chances of weak zonules. So through that gap, silicone oil can migrate into the anterior chamber. So we have to always maintain the positive pressure, and this is better achieved by using heavy OVD like Viscoat or Hylucoat. And this antagonizes the forward pressure exerted by silicone oil on posterior capsule. So coming to capsular access, anterior capsule is stained with the dye, and then the dye is displaced from anterior chamber by injecting viscoelastic. So we have to begin injection at 6 o'clock position and gradually filling the AC completely till 12 o'clock. So by this technique, you will not give a chance for hypotony, which may result in silicone oil migration anteriorly. And enough viscoelastic should be injected in AC to flatten the anterior lens surface, which is usually more than usually anteriorly convex, to prevent peripheral extension of rhexis. 5 to 5.5 mm capsular access is ideal. So the problem with smaller capsular access is that later on patient may develop anterior capsular phimosis, and bigger capsular access, the problem is that the chances of runoff is higher while attempting a bigger access, and even post-operatively the intraocular lens may migrate into the anterior chamber because there is less anterior rhexis margin which is remaining to support the lens. So lens may migrate into the AC also. So ideally, some say 4.5 to 5 or 5 to 5.5 mm rhexis is preferred. So in this image, if you can see here, the rhexis is roughly around 5 mm. So coming to hydro procedures, so in preferred cases, hydrodelineation is done to dislodge the nucleus from posterior cortex, and nuclear fragment emulsification is done in the pupillary plane away from the posterior capsule. And hydrodissection is done to remove posterior cortical matter from the posterior capsule without the need to manipulate posterior capsule much. And coming to cortex aspiration, the technique is to go under the anterior capsular flap with the irrigation tip directing one stream towards the posterior capsule, pushing it back, and others dislodging the cortical matter towards the pupillary area, where the aspiration tip aspirates them safely. So usually it is advised to keep high bottle height, to keep AC deep, and to counteract the forward force created by silicone oil. But sometimes there may be fluid misdirection also. So in that case, there will be constant shallowing of the anterior chamber. So if we suspect any anterior chamber fluctuation or a narrow shallowing of anterior chamber despite usage of viscoelastic, then we have to assume that there might be fluid misdirection. So in these cases, we should avoid keeping high bottle height. We should operate the case in very low phaco parameters. Then coming to IOL insertion. So we have to inject viscoelastic in the anterior chamber first till the anterior chamber becomes moderately deep and posterior capsule becomes stretched. So while injecting IOL, it's better to keep some viscoelastic in the injector in front of the IOL to open the capsular bag and push the posterior capsule posteriorly. So should try as much as possible to let the IOL enter totally in the capsular bag with the injector to avoid further rotational manipulation. But if you fail, you should try entering the upper haptic into the bag with least manipulation to avoid silicone oil anterior migration. Then in some cases where shallowing of AC is suspected with anterior migration of silicone oil, it is wise to leave viscoelastic in the AC. So post-operative anti-glaucoma medication should be given in these cases. wound should generally be closed by suturing, again to prevent the anterior chamber collapse. Uh, so obviously there are few challenges and solutions to that in operating these cataracts with the silicone oil. First will be emulsified silicone oil in AC. So it is managed by injecting viscoelastic into AC, directing the oil out of anterior chamber, and migration of silicone oil in AC. So again, as I said before, this can migrate either due to posterior capsular defect or due to the weak zonules also. So this is avoided by continuously reforming the anterior chamber with viscoelastic during all steps of surgery. If still silicone oil is migrated into the AC, then it can be removed by phacosuction. And if large amount of silicone oil is lost during the procedure, then silicone oil should be added at the end of the procedure if the surgeon feels the retinal state is not safe with silicone oil underfill. And it is done through infusion cannula inserted through pars plana to secure retinal state. So here you can see emulsified silicone oil droplets in the anterior chamber. So by injecting visco in the anterior chamber, we have to direct the oil out. So again, here you can see emulsified silicone oil in AC. So here during the lens nucleus manipulation, you can see the silicone oil bubble which has entered in the anterior chamber. So it can be removed by suction, or you can again inject viscoelastics to remove the silicone oil. So extensive posterior synechiae. This is managed by injecting visco in the AC, followed by breaking the posterior synechiae with an instrument that can engage the edge of the pupil bluntly without injuring the anterior lens capsule. So in cases of non-dilating pupil, the first step is to break the posterior synechiae if present, and then inject 50% diluted intracameral adrenaline. If this fails, then a mechanical pupillary stretch technique is used with injection of viscoelastics in AC. And iris hooks can also be used if the above measure fails. So dense posterior capsular plaques, these can be managed by leaving the plaque untouched intraoperatively and inserting IOL in the back, and then later doing YAG capsulotomy. Silicone oil rarely comes out of YAG opening. If the posterior capsular plaques are not so dense, sometimes it can be removed by posterior capsule polishing also. So here in this case, you can see there is a posterior capsular breach through which the oil is entering into the anterior chamber. So here in this situation can be tackled with injecting enough viscoelastics and forming the anterior chamber, followed by slow removal of silicone oil. And since the rent is big, you can implant the IOL in the sulcus, and optic capture has to be. And so coming to complications, so post-operatively, these patients are followed up more regularly than routine cataract surgery because the chance of worsening of diabetic retinopathy status as well as cystoid macular edema formation are very high in these patients. So topical NSAIDs and hourly or 2 hourly steroids with antibiotics is preferred, and there is increased risk of iritis and anterior chamber inflammation also. So this can be tackled with the usage of cycloplegics also. And if very severe inflammation is there, means we can use subconjunctival midricaine also post-operatively to tackle some of these complications, and more danger complications like reed retinal detachment and all should be managed. So to conclude, slow meticulous and low parameters are recommended to manage cataracts in silicone oil filled eyes. So we should never allow AC to collapse, as it may lead to oil migration in AC. Anterior chamber should always be maintained by injecting enough viscoelastic. Use of silicone oil is generally avoided, and main incision is preferably sutured to close off the case. So,
surgeon has advised for removal of the cataract, and oil removal is not yet planned. This is quite early post-operative period, just 2 months, and there is almost near total cataract. So in such cases, you have to be careful about posterior capsular touch during vitrectomy. CCC is difficult in these cases because of the silicone oil upthrust. So always try to use these small side incisions which keep the antechamber watertight all the time, and use viscoat or hylucoat to keep the antechamber pressure maintained. And it's better to avoid excessive hydrodissection where you are expecting a posterior capsular tear which might have occurred during the primary vitrectomy surgery. So if you can watch for the posterior capsule on slit lamp and check if there is any capsular touch, you have to be even more careful during this surgery. And even if you cannot see, just make sure that you have the posterior segment surgeon ready in case there is a tear and oil starts spilling out. So once the antechamber is filled with hylucoat, which is combination of chondroitin and hyaluronate, you start with the spiraling technique. So unlike intumescent cataract, where once you remove the intralenticular fluid and reduce the intralenticular pressure, there is no further upthrust. In these cases, because of the silicone oil, which is lighter than water, it is continuously pushing the lens anteriorly, and if there is a leakage from the antechamber anytime, it is going to cause outward movement of this capsular access edge. And I have seen surgeons trying to do it, and the tear just goes out radially without giving any time for the surgeon to react. So this is the best way to do it from the side incision, and just for the last bit I use the microcapsular access forceps through the main incision, making sure there is no leakage of viscoat from the main incision. I didn't do any hydrodissection here, and just because this is a soft cataract, I just want to aspirate it out. I'm very carefully looking for any posterior capsular rupture here. In case it is noted and there is a oil egress, we can use viscoat or hylucoat to plug that area, and then continue the phacoemulsification. But if there is excess amount of oil which is coming out, the posterior segment surgeon has to be consulted. These cases with silicone oil filled eyes, the posterior capsule generally is quite thick because of the presence of oil, and if there is no breach in the posterior capsule during the first primary vitrectomy surgery, usually it is very safe and there is very less risk of posterior capsular I think the video is paused. Okay. Anyway, most of the points are covered, I think. Yeah. Bit I use the, and there is very less risk of posterior. Okay, it's okay. We can go ahead. I think most of the points are
Yes.
covered.
Okay.
Okay, so what are the cases? Generally, we plan cataract surgery with silicone oil removal usually. Okay, so what are the
Yeah.
cases where you don't plan, like you plan the cataract surgery separately? What are the situations?
Like if there is a direct like instrument touch where the cataract develops very rapidly, sir.
Hmm.
So within few days to months it will develop. Then silicone oil removal will not be planned, sir. First we'll operate cataract surgery.
Okay, yeah. So early cataract and where you cannot see the posterior segment, so you don't want to remove oil as such. Okay, so that is one indication. And
Uh, then, like in complicated retinal detachments, sir, especially with PVR changes and all, where we need oil tamponade for a very long time. So, in those cases also.
correct. So where we are not planning to remove it, the oil, we want to keep it as it is, right? Correct.
Yes.
Okay, fine. And what are the, like in video, I clearly mentioned that main thing you have to worry about is the upthrust. Okay.
Yes.
So most of the initial parts where you are doing CCC, it's better if you do it through side incisions. So visco leak is not there, and generally try to use the high viscosity dispersive agents. Okay. And when the oil starts coming in the AC, I think there was another video where I showed that using visco, you can push it back. But
Yes.
in that case, there will be little leakage. And then you have to consult retina specialist, or you have to make sure that if the oil fill was okay or not. If it has leaked a lot, then we may have to refill the silicone oil. Then another thing is that sometimes these silicone oil filled eyes have additionally band shaped keratopathy also developing. So in those cases, we may have to do the BSK chelation first, and then afterwards we can do cataract surgery. Okay, any questions, Shishir? Am I audible?
Yes, sir.
Okay, any question?
No, sir.
Okay, okay. So should we end the meeting then?